All right, everyone. We're going to try to make this a little bit interactive and talk about some things. It's kind of a broad topic, but we can focus on things that will be helpful for your practice as you tackle difficult cases in the anterior hip or even your basic ones. Having the right tools for the job can make the job a lot easier and a lot more enjoyable. So with implant instrument selection, we want to accomplish a few goals. We want to optimize the hip biomechanics. So the parts that we're using, we want to make sure that they recreate the anatomy the way that it's supposed to be recreated. We want to do this in a safe and effective manner by also minimizing the soft tissue trauma. That goes for both the implants and the instruments. And we want to make this a very reproducible and efficient process. This is the take-home message probably for the entire talk, is that you can use anything you want to. Any implant or instrument is not necessarily approach specific. You can use these tiny little stems that are supposed to be quote-unquote anterior friendly, or you could use a 250 millimeter full straight fluted stem. These can all be accessed from the front, and yes, they do have varying degrees of exposure that's required for these things, and some designs do make this job easier than others, and we'll talk about some of the things that make that easier. Little audience participation here. Let's see what kind of stems people are using at this point. Anyone here who's using like a what we'll call a tapered wedge, so ML taper, Tri-Lock, Accolade, that type of stem. Okay. And then like a fit and fill Riemann broach system, Summit, Echo, that type of stem. Anybody using that? And from the anterior approach? Good. Triple taper stem, like an Actis, Emphasis, Z1. Fair amount using something like that. So as you see here, just from the variety of responses from the audience, you can use any of these stems from the front. Collared versus collarless. Who here is using a collared stem on their primary hips at this point? Good. All right. And then from that point too, they're standard and they're short length. There's these microplasty stems that can be used. Reduced distal tapers, recessed shoulders. These are design things that are hopefully helpful for the anterior approach. One of the things that I think is most difficult for a lot of people to understand in some of these stem designs is varus is okay in an anterior approach, especially with a triple tapered collared stem. Having that implant and a little bit of varus is actually more protective than putting it over in valgus where the collar doesn't engage with the calcar. So that's something that takes a little bit of time to get used to. Putting these in with offset broach handles, the lateral or anterior, and using automated impaction are all tools that can help on the femur side. So this is a picture of a couple different insertion broach handles. So when you're putting the femur in, you can either, of course, use a table or table-less. From the audience here, who's using a HANA table or traction table, some sort of table? And then the opposite, using no table, using a standard OR table? Very good. So as you see there, the exposure that we have for each of those techniques can be a little bit different. The instruments we use to help expose the hip can be a little bit different, but again, it's finding the things that are suitable for your workflow, your approach, and your team. I think that as we're broaching, broaching the topic of broaching, avoiding malalignment is very important. So some folks use the dual offset broaches. I use just a standard anterior offset only, or just an angled one as I'm using my automated impaction. Again, it's whatever you can consistently use in your hands to get the same job done every time. So in my hands, what I do is I use a triple tapered stem using automated impaction. I like a stem that has enough length to get good fixation, so it's not so short that it's difficult to tell my hip alignment. I think that these stems are helpful because they do require a little bit less femoral release. You can put the stem in a little bit of varus, and it's still a very safe and effective way for that stem to be in place. And then one of the things I like in the design of the implant that I use is there are consistent neck lengths. So if I go from a size 1 to a size 8, there's no change in that leg length or offset as I'm trialing. So I could take a fluoroscopic X-ray image and I can say, hey, look, my broach is really small here. Let's go ahead and go up to a 2 or 3 sizes, and it's not changing the leg length offset that I just measured, which makes that mental math that you have to do as you stand there in the operating room trying to do trigonometry a lot easier. Kind of hit on the idea of automated impaction. Who here is using some sort of impactor in the OR? Cool. So the advantages, I think, of automated impaction are they can help you provide a very consistent force, both in direction and in power. So automated impaction allows you to have direct linear force while broaching, while putting cups in. That makes your bone envelope much cleaner, which I would think would also help a lot with the fixation of that stem long term as well. Also helps on the cup side of things, so you don't have these glancing blows. You're not jostling the cup each time you start to impact it. Lots of different tools, obviously, everything from offset to straight cup insertion. There's different types of offset on your femoral impaction. You can impact the head, you can impact the implant. Some of the other companies have even more things where you can use osteotomes to remove stems and osteotomes to remove cups. And I think we're just starting to see the beginnings of what this automated impaction can do in the anterior hip. So I think we'll see lots and lots more accessories coming out in the future as we find more utility for this device. And again, the insertion handles, there's different liner options in using automated impaction on the cup. The cup's kind of the more simple thing. There's not a lot of variety in the different types of cups that are anterior specific. I think, again, using a cup that you can get seated well and that you can consistently position well. I think using a cup that has the ability to use fluoroscopy to help estimate or measure your inclination and anteversion is a helpful aspect of a cup as well. So when putting in a cup from the anterior approach, who here is using some sort of curved insertion handle versus straight? So curved, so about half it looks like, and then straight insertion handles, again, maybe closer to a little bit less than half. Again, I use a straight. You can use whatever you'd like. Again, the take-home message of this talk is finding the tools that work in your hands consistently. So I think that acetabular reamers that have anterior access are as helpful. They make small little reamers that are half basket. They're supposed to be easier to put in. I just use straight reamers. I use straight reamer handles, straight reamer, and I can still use the straight handles for even a bikini anterior hip. So it's all about planning this out and using things that you would normally use. On the retractor side of things, again, there's a million different ways to skin this cat. I think the thing on the retractors that's really helpful is minimizing your soft tissue trauma. So if you look at most of these retractors that are up here, they have flared edges so that when you're putting pressure on the skin edges, you don't have a sharp edge that could be cutting through a muscle belly or putting an abnormal amount of force on those on that skin or soft tissue that you're there. So we're trying to minimize soft tissue trauma. Also, these longer handles are nice. They give you more lever arm, and they make it more comfortable and ergonomic for your assistants in helping with positioning. Like everything in life, you can make this as simple or as complex as you want. I'm one who likes to try to make it as simple as possible. I try to make it with as little variable each day so that when we're going in the operating room, you don't have to have this fancy tool that has 15 moving parts work just to have a successful surgery. So think about what you're using and how can you simplify your workflow process so that when you get the random scrub tech who just graduated school who's never seen a hip before, it's not a big deal. You're like, here, hold this one retractor here. That's your job. You don't have to teach them how to construct this really elaborate retractor set. It can be very, very simple. And then I'll quickly hit on this. I'll just say that navigation and imaging is a tool. It's something we'll talk about through other talks here, but I think making sure that your instruments and your implants are compatible with what you're using in the operating room. So whether it be the consistent neck sizing on the femur or having an acetabular component that shows the ellipse really well when you take fluoroscopic images, being able to use these technologies in the operating room will be not only something that makes your surgery more precise, but it's going to give you a lot of confidence as you're getting started to say, I'm leaving the operating room with a hip that's stable and a hip that's going to be one that my patient really, really enjoys. So, and then I don't think that's really about. So yeah, summary. just use what you're comfortable with. Use things that help with your visualization, minimize soft tissue trauma, and can hopefully help use technology to make that make the job that you're trying to accomplish more reproducible. So. All right. Any questions? Cool.
All right.
Thank you.
Thanks,